Kane with HIT 330. This is Healthcare Delivery Systems. We are now on week 11. Week 11, wow, time is flying. And we are on chapter 11, Health Information Systems. We are still using unit objectives 9.8.1 through 9.8.6 if you are looking at your syllabus. I want to stop right here for just a quick second before I go into the slides because I wanted to talk to you about your book. I know that this textbook is big and it is bulky and it was probably very expensive. And you're also probably wondering, well, it's not as detailed as what it could be. But I want to tell you that your book is one of the most critical books to have when you start in the last half of your second year of the degree program or whenever you're finishing up the HIT program. It will be one of the most critical books that you have to study for your RHIT exam. Now, it's not just me saying this, because if it were just me saying this, it really would be meaningless in many ways, because I never sat for the RHIT exam. I had to sit for the RHIA exam when I finished because I entered the program late. So I never did the associate's degree. I just jumped straight to the bachelor's, which is a long story in and of itself, but I will not bore you with it at this point. My point is that this past spring, when I was talking with many of the students who were finishing the program and they were getting ready to take their RHIT exam, several of them said, I didn't realize how important this book was. I didn't realize how much I would use it to study from. It's got so many concepts in it and the definitions are there. And they went back to it and really used it to study. So I want to encourage you, first and foremost, don't sell this textbook. Keep it. You will use it again and you will need it. So please, please don't sell it. Hang on to it. And hang on to it because when you go to study, you'll need it. So if you are frustrated with the textbook at all, I just encourage you to somehow find a way to at least get to a point of acceptance with it. You don't necessarily have to love it, that's okay, but I need you to get familiar with it, really utilize it, memorize the terms in it, and hang on to it because we will come back to it again. All right, so enough about the textbook because you're here for chapter 11, right? We are going to focus this week on the EHR versus the EMR, and we will touch on meaningful use. Meaningful use is now meaningless because it's pretty well gone away, and we'll talk about that. It has transitioned into what's called MACRA, and so that's why you have an assignment on MACRA and not on meaningful use. However, we are still sort of in an interim period where AHIMA, the American Health Information Management Association, has still not updated their RHIT exam to eliminate their questions about meaningful use. So even though meaningful use essentially does not exist today in the real world, AHIMA's test is a little bit far behind, and they're still using questions from it. So I have to teach it to you, and you have to be aware of it, but the real world is MACRA, and AHIMA will be switching to MACRA, but I don't know when that is, so it's best if I teach you both. How's that? Okay, so moving on. First thing we're going to talk about in Chapter 11 is the Office of the National Coordinator for HIT, for Health Information Technology, called ONC. If you are looking at your book, your handy dandy textbook, we are on page 321. And that's just where the chapter starts. But if you're wanting to learn about ONC, it is on page 323. And that's where we really get into what the Federal Health IT Strategic Plan is and how they're trying to advance that. And this talks about ONC's vision of high quality care, lower cost, healthy population, and engaged people. They want people engaged in their healthcare, people being part of the decision-making process, people who are wanting to learn more about their condition and other alternatives or ways to live healthier, to manage their condition, those types of things. Their mission is to do that through the use of technology, making sure that health information is accessible. So they're trying to do that again through technology. They're trying to, those electronic records, those EHRs, they're trying to get rid of paper, make sure everything is electronic and that it's accessible. And they make sure that it is through health information exchanges and through what is called interoperability. And so we will be talking about that. I wanted to see in your glossary if they have interoperability here. They really should. This is such an important term to what we're talking about. Yes, they do. Very top of page 741 in the back of your book in the glossary. Interoperability, the capability of different information systems and software applications to communicate and exchange data. Please make sure you study that definition and are very familiar with it, because really essentially ONC boils down to two things. They want electronic health records and they want interoperability. That's their mission, because what they want to do is use those to increase the quality of care, lower costs, create healthier populations, and create an environment and a culture where people are very engaged in their health, their decision making, and all of that. All right, so enough beating on that. This is the Health IT Plan 2015 to 2020. So it's ending here in 2020. It'll be interesting to see what they come out with next as to what their next steps are. But they want to advance person-centered and self-managed health. They want to transform healthcare delivery and community health, and telehealth is a big way that they're doing that, especially through COVID. They want to foster research, scientific knowledge, innovation, and they want to enhance the nation's health IT infrastructure. They have a lot of community and rural broadband activities going on. And we will go into this in more detail in other classes next fall. If you're still on the program track with this, you'll be taking some classes where we actually go into and we look at rural connectivity and what the government is doing and all of that. I know that because I'm teaching that class right now, so this dovetails really nicely with that. All right, so they want to collect data and information. They want to share it through interoperable systems. What did I tell you about that interoperability? They want to use that knowledge to support a learning health system that achieves value. They want to improve the quality of care while reducing the cost. And not only do they want to improve the quality and reduce the cost, they want to eliminate unnecessary procedures and treatments and things like that. They want to use what they know has been established as best practice, evidence-based. So when we talk about health information systems or health IT, and this is at the bottom of page 323, there are components of the HIS system. And it talks about hardware, software, communications and network technologies, people, policies, and process. Those all work together to support the goal of improving the health and well-being of the nation, or at least that is the theory. The current state of health information systems, there's regulation versus actual practice. Is that not true in most of life? Here's what we want you to do, but here's what's actually happening. Under regulation, they have under let me start again. I might even need a drink of my iced tea for this. All right, so in terms of regulation, remember we talked about how HIPAA came, and then shortly after HIPAA was ARRA, and under ARRA was the subsection called HITECH. What HITECH did was they offered what was called meaningful use. It was an incentive to pursue electronic health records, and it came with money, lots and lots and lots of money for healthcare organizations who could prove that they had met these requirements of meaningful use. So there's that piece. At the same time, CMS was changing up their payment programs and really focusing on quality. And they also wanted to push promoting interoperability. And this is on pages 325 through 327. It really looks at all of this. How this translates into actual practices, they wanted to see all this implemented. They wanted to see EHRs implemented. They wanted to see how they were using and proving meaningful use. They wanted them to adopt more of the quality metrics and optimize how health information was being utilized with workflow, process improvements, clinical efficiencies. So that's how regulation was meant to impact actual practice. All right, I think this is a great visual. And you'll see this again in another class because I've used it for another class. To make up an electronic health record, you have source systems, clinical core EHR applications, supporting infrastructure, and connectivity systems, however you want to say it. And in another class, we actually go into all these in detail and study each one. You don't have to do that today. What I really want you to notice is that there are so many components that go into an electronic health record. There's everything from the master patient index and patient financial service to quality, to the lab information system, radiology's information system, also known as the RIS, and the PACS, which is where they archive all of their films. Inpatient pharmacy system, there's other systems. There's clinical specialty systems for places like the emergency department, surgery, anesthesia, emergency medicine, all those. And then there's smart peripherals. These are the things that kind of plug in and upload their information, like infusion pumps and monitoring equipment like vital signs. You can have blood pressure cuffs that are plugged in that monitor the patient and then upload the information directly into the system. There's also some things with robotics that are being done. Dispensing devices can include what is known as like a Pyxis system, where the pharmacy system has all the medications and nursing goes into the Pyxis system, pulls out the medication, uses barcodes, scans it, makes sure they have the right patient, the right medication, the right dosage, all of that. And that uploads into the patient's medical record. And they also scan the patient's wristband so that it's all together in the information at the time that the medication is being dispensed. And then you've got your CPOE, which is your electronic ordering system. You've got point of care documentation, clinical decision support, where it helps you based on all of the information that's going on to know what is best practice, evidence-based, or what should be explored next. And there's reporting and analytics. You have interfaces, you have registries, you have all types of stuff. And then you have other items that plug into that enable you to do telehealth, have patient portals, storage area networks, and on and on and on. And if you're looking at this is page 328 in your book. So, source systems, what are they and what do they do? And this will talk about what they are. And I'm just going to skip through these. I just want you familiar with them. We go into these in depth in another class, but you at least need to be familiar with this to understand that the major components of an EHR are source systems, core clinical EHR applications, supporting infrastructure, and connectivity systems. If you at least know those four, you are steps ahead. If you know that under source systems you have administrative and financial apps, ancillary clinical department apps, specialty clinic systems, smart peripherals, that's even better. Not necessary, but better. If you know examples of what's under each one, that will really be helpful moving forward. But if you're not familiar with any of those, that's okay too. We really just want to introduce it here so that it's not a complete shocker when you get to other classes. So that's where you're going to go through and you're going to talk about source systems, then you'll talk about EHR systems, then infrastructure, and then connectivity. So I'm going to skim through some of this because it's so well written in your book and it's right there for you. And again, anything that's in that teal font, if you're not sure what it is or it's not clear in what's written in the book, go to your glossary and check it there because it may have some additional information for you. And again, this just goes through the different types. And then we get to transactions and clinical data. And if you're still with me in your book, we are now on, where are we? We are, where are we? Just a second, let me find it. And I really like, let me step away from this slide for a minute and make a couple of notes about your book. Your book does a really good job of going into a lot of these specific systems and talking about what they are and what they do. So take your time and go through these pages. I would say starting with good old page, I guess it would be 327. From page 327 to 3. Really to 348. There's just such good information in there. And I hate to try and lecture it because it's really, I think you would get better information from the book. It gives you a little more detail. And I hate to repeat what you can read. But getting back to this slide, HIPAA transactions and clinical data, it's at the bottom of page 330. And what this is trying to show is how, with HIPAA, what format the data, how it works. Where is it going? What systems is it going into? And what's happening at that time? And who is the data being exchanged with? Where's the transaction taking place? So let's start at the top. So if you have a sponsor, they're involved in enrollment and premium payment, and that information is going to the health plan. If you are talking about admitting diagnosis, that's typically given by the physician who admits the patient. So it's coming from the provider. It's utilized by a lot of different people. It's used for eligibility verification, prior authorization, referral request and response, and it goes into the pre-adjudication expert system where they're talking about, is this admission justified? Are we going to approve it from a financial standpoint? Then you look at the charges for clinical services. Those are being entered into the system or accrued within the system through the billing software. And it's being done by the staff as they're putting information in. It's also being done sometimes by a coder. But it goes through the billing software, ends up on the claim encounter, and that goes to be part of the claim adjudication. Then you have what's called AR, which is accounts receivable. They're interacting with claim adjudication and accounts payable because you've got the claim status inquiry going back and forth, response, that should say response, not response, but response, and remittance advice when it's paid, and the electronic funds transfer that are taking place from the green, which is going to be the payer, and the blue and red, which is the organization and the patient. At the end, to judge the quality of care, the organization has some business intelligence software that takes a look at that, and they are able to share that information back with, whoops, come back here, back with the health plan for disease management. So that's how this one works. All right, revenue cycle management, that is sort of some of what I was talking about, but these are all parts of revenue cycle. If you've ever heard of revenue cycle, it's all these things. It starts with patient registration or from the patient's first contact with the healthcare organization if there's some type of scheduling or pre-admission process, that type of thing. And it goes all, or a pre-authorization process that could be happening all the way through the end to the point where the payment has been received, it's been posted, any other accounts receivable or outstanding bills have been followed up or collected, or the account's been turned over to bad debt or charity management, and then reports are done on it. And you can see all the different steps here. And let's see if there is a section on revenue cycle management here. And don't worry if there's not, if it doesn't go into a whole lot of detail with revenue cycle, we will cover it again. Probably, I'm not sure if we will in this class. There's just a really brief section on revenue cycle at the top of page 329. And this slide is at the bottom of page 329 in your textbook, but have no fear, we will cover it again. It's just to make you aware of what revenue cycle management is and the different steps that are involved, but you don't need to know them or have them memorized. Okay, so HIM systems, that involves master patient index, coding, clinical documentation integrity or improvement, documentation imaging systems for scan documents and managing those, speech dictation, discrete reportable transcription, consent management, release of information, and chart tracking. And again, we will cover these again and again and again. And then it goes into the core clinical EHR systems and what all those are. And I'm not going to spend much of any time here because it's all in your book. It's just a matter of reading your book and really studying the definitions and the items and being familiar with them. And so it talks about these for medication management. This is an example of core clinical EHR when it comes to ordering. You see at the top the order is entered, usually through CPOE, but it could be electronic prescription ordering. Whoops, come back here. And then from there, if it involves patient data, and then based on evidence-based medicine, it'll say whether or not there are alerts, like food and drug interactions or drug-to-drug interactions or that type of thing, or allergies, patient drug allergies, that type of thing. If there are none, then it allows the order to continue or the prescription order to continue. But it takes into I'm sorry, why does that keep happening? Sorry about that. It takes into account the patient, drug knowledge, and evidence-based medicine. What is best, what is not. And then it looks for alerts. So what if you do get an alert? If it's a bad alert, you should not override it because that's alert fatigue and that could cause major problems for the patient. If it's if it's okay, and sorry, let me try that again. Okay, so yes, you got an alert. So there's a problem with it. You should be changing the order. That's the bottom line. You should be changing the order, but sometimes providers get what's called alert fatigue, and they don't. They override it and let it go anyway. And I'm not going to talk about the the wherefores beyond that. All right, so we talked about that. This is what happens when the order goes through to the pharmacy, okay? And the pharmacy has access to best practices, patient data, and then it's off to nursing. And the MAR is medication administration record, and that's nursing. That's where nursing understands, oh, this drug has to be given orally, or no, this drug has to be given intravenously, or no, it needs to be IM. But they have access to patient data, drug knowledge, and their nursing best practices. It gives the system then is tied into an automated dispensing system, barcode labels and readers, automated monitoring devices, and AIR or ADE reporting. And if you're wondering where I'm on page 335 when we're talking about medication management and CPOE systems, how those are linked and what they do. And that continues into page 337 with a BCMAR, barcode medication administration record. All right, so onward and upward. Many types of clinical decision support, and if you're wondering what is clinical decision support, it is a key component of the EHR, and it helps physicians, nurses, other clinical professionals, collectively referred to as clinicians, as well as sometimes patients themselves, make informed decisions about patient care. They have active alerts where they are set up and they just go off. They have passive alerts, which are sort of reminders or buttons where you can click for more information. They are usually integrated within the EHR. They can be standalone, but for the most part, clinical decision support these days is integrated within the EHR. And it's offered at many points in the use of the EHR. What it's there for is to really try and help clinicians so that they don't have to remember everything. When you think of the thousands of drugs that are out there and all of the different side effects and contraindications and all of that, it's impossible for one human to remember everything perfectly all the time. And that's what these clinical decision supports are there for, is to help remind clinicians, oh, hey, you forgot about this, or oh, wait, watch out, this is significant. You need to know that this is a big interaction, or this patient has an allergy to it, or stop, don't go any further, or hey, did you forget to chart this or check on that, or it's going to be time in 10 minutes for this patient to have this medication. So that's because this medication is optimal if given every 4 hours, and so it's all those types of things. And this just shows you the flow of it. And this talks about data quality. And that is on I'm looking for where it is in your book. I've lost my place again. Sorry about that. Give me a second here and I will find it. Well, anyway, it's not highlighted quite the way I was looking for it. But anyway, on page 340, I believe it's all in there. And it talks about what is data quality and what is all a part of data quality. How can you assure it? How can you help it? It mentions data dictionary and some of these other things, as well as attributes and um, semantic interoperability, data models, all those types of things, artificial intelligence. So I'm going to just refer you back to your book for that. Pages 340 and 341. All right, on to supporting infrastructure. Again, this is in your book, and you can take a look at that. It starts on page 342 and goes on from there. These are all the different types of components for supporting infrastructure. Talks about connectivity systems on page 344, and that's where we're going to get into telehealth. And again, this is really to introduce you to all of these concepts. Talks about low tech and high tech. And then patient exchange health information. This is where we get into patient portals and personal health records. And again, you will go through this with a lot more detail in other classes, but you at least need to know what is a patient portal, what is a personal health record, and how are they different, because they are very different. And this is all on page 346, in case you're wondering about where we're at. Clinical document architecture, and this gets very technical. Again, you will go over this later. For now, I wouldn't be too worried about it because, again, this has to do with the Meaningful Use Program, and the Meaningful Use Program closes in 2021, and most organizations were done with the Meaningful Use Program in 2018. So it is, for the most part, is meaningless. You just need to be aware of it, I guess. HIEs and HIOs. What are the difference and how does that work? This is starts on page 347, goes into 348. There's a good visual for this. Did they give that to us? No. That would be too easy, wouldn't it? All right, look at page 348 at the top of the page. That talks about HIO services. Right after it explains about health information exchanges. And that you do need to know what a health information exchange is, and you do need to know what a health information organization is as well. HIOs used to be fairly common when all this took off, but they have really scaled back as time goes by. And as interoperability has increased. And so this talks about e-health exchange, how HIOs transitioned really to be more e-health exchanges. And this goes into systems development lifecycle, which begins in your book on the bottom of page 349. You identify a need, you specify your requirements, you design or acquire, you develop or implement, you maintain it, then you monitor your results, and then you see if you identify any needs, and it repeats. It is a cycle. And this is applications. You can use it for strategic planning, clinical quality improvement, health information system selection, which it is very helpful for, and optimizing the use of health IT. So please make sure you are very familiar with systems development life cycle, those steps. What order they come in, what the steps are themselves. Under Identify Needs on page 350, it talks about SMART goals. And this week, you will have an assignment on SMART goals. So you will actually be putting together SMART goals because this is really important. This is something that you need to know how to do, whether it's for your own self or for professionally. SMART goals are something that a lot of places use as a common practice. And so that's this slide. I guess I got a little ahead of myself, sorry. And then your specify requirements goes through what this is and how this works. And this is page 351 in your book if you're wondering. Design or acquire, what does that mean? Develop or implement, how is that done? Maintain and monitor, what would help with that? And that is it. That brings us to the end of the chapter. So, week 11, you have a discussion, 2 assignments, and a quiz on chapter 11. I hope you're doing well. Take care, and we will talk soon. Next week is week 12, and we will be doing chapters 1 and 5, catching those back up and really focusing on the HIM profession and AHIMA. All right, take care.